doctor's office. She's going to be joining us. Between several of us, we'll take notes and roll. So, Mike Brower.
Present.
Sarah. Sarah, you there?
I am present. Good morning.
Robin? Sandra?
Here.
Gary? Here. Jason?
Here.
Mike Kage? Ken?
Here.
Monica? Keith? Well, thanks for everybody for showing up here in person and via the WebEx, and thanks for our visitors here as well. Couple of things. So I think how we'll proceed, and we obviously change in the middle, but we'll take care of some normal business and get updates, and then we'll turn to CPPR with the presentation and the way I would like, even though it changes, but they have a lot to present, as we know, and then maybe the latter part of their presentation introduce some tools that are interactive, and those that have brought their laptop, perhaps can follow along. We'll see if I can, probably the rest of you can, but and then we'll break for lunch and then come back for Q&A. And I know several people, me being one of them, will I need to depart to be back in Dodge City tonight. So probably somebody that's here can conduct the meeting and close us down when we get done. The other thing, just to put out there, and maybe the next board meeting we can actually adopt this, but several have asked if there's term to our board appointments. So I don't think there is, but we can, establish that, probably 3-year terms or 4-year terms, which would be, roll over, and it's always good on a board to have some continuity, but also, some new blood. So we'll check on that and establish. Now, of course, we do have 1-day terms in that we're all appointed. So at any day, I know in a previous position that I held, people ask, is that an elected position? And I'd say, well, it is, but I only have to get 1 vote, but I have to get that every day. So that's kind of, we serve at the pleasure of those that appointed us. With that being said, let's move to the board minutes from the June board meeting. I will look for a motion to approve.
This is Sandra. I move to approve.
Sarah Kayla will second.
Seconds. Any discussion? Seeing none, all in favor, aye.
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 Those opposed, same sign. All right, unanimous. Now turn to Chris for any updates from the AG's office.
Well, thank you, Mr. Chair, and thank you, board. I do have just a couple of updates. You may or may not have seen, since I was last here, since I was not able to be here last meeting, that the Purdue bankruptcy settlement process has reached a public resolution, although we are still getting through the final steps. So I wanted to give you a little more information on that particular arrangement. And the reason I'm using the word arrangement rather than settlement is because it includes both a bankruptcy plan that has to be approved by a bankruptcy court and a separate settlement agreement that has to be approved by a separate Kansas court. So this is probably the most complex resolution that we're talking about. But the high level is expect north of $30 million for Kansas over about 15 years, and I say about because there's prepayment and options that are associated with bankruptcy, and you know all of the caveats. But that's going to be an additional sum of money that will support us for additional time. It likely will terminate after we've been kind of talking about 2038 as the final year. I believe this one will run a bit past 2038. So just know that if we do have board terms, we're going to expect board members for another long period of time. But we are excited. Don't expect money out of that likely this year, just as the process is going. If it does come in, it will be very late in the year, that first payment. So just know that that is a process that we are working through to get the subdivisions on board, to get all of the votes and things that we have to do to get across the line. But that's going to take, a number of months still to resolve. On top of that, we have what we are calling our secondary manufacturer settlements, which is a series of 8 settlements packaged together that are very small for small manufacturers. And that the embargo on that press release released yesterday, so I can talk to you about this. It's about $5 million for Kansas over a variety of schedules, so not a lot of money. The more exciting part is that, assuming the AG elects to take it, there is a product component, much like the Teva settlement, so we will be working through how to properly distribute that, and while nothing is certain with the Teva product component, we went through the state naloxone program. I anticipate that we will probably utilize a similar process, although nothing, again, is finalized on that. So just know that we will be getting more naloxone. It's not, again, a substantial amount, but we are getting more to add into the state naloxone program, which is quite exciting on that particular front. Couple other updates. One is that we continue to get some interest in what Kansas is doing from national media. Kaiser Family Foundation has taken a strong interest in reporting on what every state is doing, and so Chris and I were working with them to just give updates about how we were spending our money, and in that process, we realized that there's probably some refinements we can do to our annual reporting. So just this is now me projecting 9 months into the future, but anticipate that we will probably have some more detailed conversations about ways to refine the way we report, how we grant money and how we spend money, and kind of the distinctions between allocations and distributions. So just to make things a little clearer for the public on that particular front. I don't think I have any other major news. I will say that with the Purdue secondary manufacturers and previously resolved Kroger settlement, I have not finalized the exact projection, but my estimate projection is that we are going to cross around 400 million for total recovery for Kansas. I'll get you the exact number once I'm able to get that particular projection done. But I'm quite excited that we've been able to push up even further. So I'm open for questions.
Questions for Chris? Remind me, so a lot of these settlements are over time. If we make a settlement with Acme Corp. and in over 10 years they have a payout, and in 3 years they declare bankruptcy, is ours one in some kind of an escrow? And if not, where do we line up with other creditors?
Yeah, so that's a good question. And I think that depends on the particular terms of any individual settlement. What I'll tell you is that in at least one case, we've already had that problem. That was the Endo bankruptcy. And the resolution was we might have had an advantageous position against other creditors, but the resources the company had just wasn't going to cover everybody. So we negotiated an alternate resolution to get us the most money that we could in a short-term payment, rather than trying to restructure in a company that likely didn't have much of a future. So my very much non-answer to your question is we would likely renegotiate what our terms were in an event of a bankruptcy for one of these companies. Right now, I don't have any concerns. There are no companies that I am concerned about at this stage. Obviously, things can change. But one of the things is that in some of the settlements, we have prepayment rights that can kind of alleviate some of those future concerns, where the business, if they're doing quite well, can prepay. Yes, it brings down the top line number, but the present value remains roughly the same and gives us some peace so that we don't have to rely on hoping that company is still around in 18 years.
Bird in hand.
Yes, bird in hand.
Again, this is, I have no idea, is there a way to file a lien or mortgage against
What I will,
debts or anything?
what I will tell you is that I believe we've resolved all of those types of questions in the settlements. I don't have the specific method of resolution in my head at this moment. If we saw a company, and I will tell you, I said I wasn't really concerned because I haven't gotten any updates in a while that there are any concerned companies. There is one company who has publicly been struggling. And so there are conversations about ways to better protect our particular settlements. I don't know that I have anything I can share at this time.
Okay, thank you. Any other questions? Seeing none, thanks, Chris. And move on to the next thing. Shanna, do you want to, you have a report for us or no? Okay. Krista.
All right, so up for the grantee items is just that final action on the thing we discussed at the last board meeting with the grantee that had 2 surgeries in their final report and considering the allowability of that. And a reminder that it was about 26,000 that were for those 2 surgeries. When we followed up with them based on the conversation the board had at the last meeting, their response related to if the client would bear the cost if this is unapproved or if the organization would. They confirmed that the organization would bear the full cost. They recognized the clients would not be able to afford it and they wouldn't cause that unexpected hardship on to the client for this issue. And then they also talked about a willingness to do an extension in their grant so that they could spend dollars down if this was not approved. They could spend those dollars in a manner in which is aligned with their original approved budget. And they mentioned things such as their community health worker, client primary care memberships, and prescription services, which were originally already in their budget. And so that would be another option if not approved.
Thank you. Questions?
This is Sandra. I've been thinking about this one a lot since we were here and do appreciate the written follow-up to keep that in mind. I appreciate the organization saying if we don't approve this, they're not going to charge the patients. I think that was my key thing. I really struggle with us approving use of grant dollars for this because that's not what we said we were going to do, and I think it sets a bad precedence if we do that. So just wanted to share that feedback.
Other questions or comments? Seeing none, would, and it is tough because they have been very upfront with what they're doing and, you know, just this, even this latest information, you know, it's not like they're trying to pull a fast one, so to speak. So just let the will of the board take over. So would entertain a motion either for declining the modification or for approving it.
This is Robin. I would move that we decline the coverage of the surgeries, especially given that they can spend the money on approved items.
This is Sandra. I second that.
Motion and a second. Any further discussion? All in favor?
Chair,
Aye.
Chair,
Oh,
Chair.
excuse me.
This is Mike. With that, do we need to approve an extension for them, or do we want them to request that later?
That's something typically that we've just done in-house as staff, but if you wanted to do it formally, that would be okay as well.
I think we need. Any other questions? Seeing none, all in favor? Aye.
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 Those opposed, same sign. Okay, the motion to decline the modification is unanimously approved, and we'll direct staff to work with the client on a modification. And any other updates, Krista?
Nope, that was it for me.
Okay, thank you. Well, now, let's see, we got some other item on the agenda to get to. So this is, first of all, I want to say thank you to CPPR and to the Sunflower staff. Alyssa and Krista, I know you've invested, I don't know how many thousands of hours, probably more than hundreds, and you know, thank God for all your help and you know, to come up with the report that, you know, in my purview, and I haven't got deeply into it, but I've been through it a few times at a cursory level, and looking forward to today, but just using this as well as other information that we'll gather over the next year for what I term our exciting part of our job. You know, we have done a lot of good over the last couple of years with our grants, but this innovation is really kind of what I signed up for, and this will be a document that we can rely upon, and you know, like anything, a day later, things are old, but this has a lot of current information and sources of information. So I think to begin with, I'll just invite Janine to come forward and introduce, why don't you introduce your staff in the order that they will present in, or if you're going to do it all, and
Good morning. I am Janine Haran, and I work with the Center for Public Partnerships and Research at the University of Kansas, and we're very pleased to be at this point and really excited for this meeting. We've taken a more conversational approach to this meeting, and when we've come in the past, we've gone through long slide decks and all of that. And we will be presenting very specific information about the needs assessment and the findings within the needs assessment. And our focus today, given the questions that were asked and the guidance that we've been provided, is really to get to specifics kind of as quickly as we can, and to start to think about how to use all of this information. And so we're excited to do that. There are 3 other members of the team who are with me here today. You know Zilka von Essenwein, who has been here all along. And behind us, with us here, is Chris Tilden, who is one of the researchers who participated. And then Jared Barton, who is also a researcher and is the CPPR CEO. So we're excited to be here. On your the handouts, which I know you have both electronically for those who prefer to do that on the computer, and we have some paper here as well. The actual focus is there on that very first slide of this particular packet. That is the context, really. What is the landscape that we're seeing, the things that we really can't control, but we need to accommodate. Many key findings from within the document itself, and the purpose, why we looked at those things. Then we'll pause and we'll move right to taking action. And we'll talk to you about how the vision was established, and that is specific to the many thousands of people who helped us prepare what we're running towards. I mean, it's really hard to plan, which is the task that you all have, if we don't know what direction we're going, and they had some suggestions for us. So we'll talk about that future vision. We'll talk about the strategic development process, and then also some specific recommendations about were we in your shoes. This is what we would consider starting with and how we would consider operating with this information. And then, as Pat said, there are some decision supports, some tools that have emerged throughout the course of the document, and we'll walk you through those and what the purpose is for those and how they can be used to achieve the goals. So I guess what I'm saying is we're here today to roll up our sleeves and to talk with you. Yes. I would like to, I haven't done this in the previous two presentations, but I really would like today to publicly acknowledge our project team. It's a 31-member team, have worked together over the last year and a half to gather, to interpret the volumes of information that is there. And it's that interpretation piece that always makes me most proud about the people that I get the opportunity to work with every day. Also included on that team are 8 individuals who we have titled the Accountability Cohort. And the Accountability Cohort are people who are representative, again, of across the state with lived experience, with expertise, and with the inclination to really dig in and to help us understand and be that gut check. And they have been there many hours as well. So I want to acknowledge that group. All of that group is noted before the preface in the report itself. But we've also had the privilege of meeting over 2,000 people on the road, so to speak, across all 105 counties who attended many of the community events and work sessions. And, they have really included a broad set of constituencies. These are people who work in healthcare. These are emergency services people. These are school personnel. These are court-related professionals. These are very eclectic crowd, people who are touching this, the difficulties and the challenges associated with substance use disorders every day. And they also provided really what they only can, which is that passion and that personal first-time experience, as well as their professional expertise in many, many, many cases there. So, we learned from them, from their candor, from their critical thinking, from their suggestions, and you see their input on every page here. It is remarkable how people came out, and it was, we would close sessions and talk about, the what next with them, and you got a big team behind you. They really want to help. They really want to be a part of what is happening and provide lift with you. So they have been a part of the big picture thinking. They have been a part of expressing the concern and reaching a broad spectrum of voices. We feel like we have really covered that. And we've done all that with a bias for action. So we understand that and then would take to the next step in terms of what do we do with that. Throughout the process, your direction has also been present, and it is something that we communicate to groups when we go out, what we keep before us as we work as a team, and that is the mitigating the impact of substance use disorders, both for individuals and in communities, in order to achieve, and we kept hearing the same things from you, and so we kept representing that forward, a sustainable kind of a path leading to healthier people and healthier communities across Kansas, with the ultimate goal of saving lives. And we kept those two things, that sustainability of the work that you're doing, the legacy piece, and the saving lives in the short run. So we believe that there is enough information here and the right information here to be able to chart that path, and we acknowledge that is not without bumps in the road. And I would also acknowledge that the circumstances and the data align in your favor. You have time, you have money, you have information, you have expertise, and you have eager partners all over this state. And so we're behind you and in full support of your success as we go forward. So I pause and just say there, let's get down to it. What's in the report? So one of the things that we realized collectively is that we collectively have been underestimating the extent and the impact of substance use across Kansas. While there were multiple indicators shared by people in community meetings and focus groups, that perspective was also validated in the 2023 National Survey on Drug Use and Health, the NISTA, where based on their very comprehensive statewide survey responses, which they do all over the country, they found that nearly 1 in 5 Kansas adults, that's about 395,000 people, meet the DSM-5 clinical criteria for substance use disorder. It's notable from their work that young adults, 18 to 25, were really the most affected. And in that group, 29% met substance SUD criteria per the DSM-5. Sadly, in that same survey, 95% of the people who met the criteria either did not recognize it for themselves or said they did not feel that they needed treatment or support of others for their condition. And so there are a lot of people out there, and they're struggling for the most part on their own, and often resulting in unhealthy emotional burden, both for themselves, for their families, and for their employers and their communities around them. That was sobering for us, and that was a challenge where we were looking for options where we can really think about the overall climate, that community level climate that would help and support people even in that particular position. And we were wondering, what is behind this? What is it? Depression? Is it shame? Is it what? Why would people wrestle with this beast on their own? That was the question, right? And what many people with lived experience told us is, it's all of that. It's any of that. And you can see on the page 2 on the bottom there, the individual path. And we've seen this slide before. But what was described to us over and over again is this pervasive fear and judgment that really results in an internalized sense of lack of mattering and that loss of hope, which was kind of heartbreaking to see and to hear people explain that to us. It's a big toll, and it has implications for both of your objectives. It describes really vividly the isolation, when what we really need to be seeing is building of communities, building of the support networks, and it also, of course, can contribute to loss of life and more lives to save out there. So let's pause and talk about that a moment, the dying of SUD, from SUD, because that is a measure to wrestle with. People can die due to long-term health and environmental complications resulting from substance use. And people can, of course, die suddenly from substance overdose. back up to the first part there. Conditions like heart problems, like lung disease or kidney failure, those are examples of long-term health complications resulting from or exacerbated by substance use. And SUD might also lead to hepatitis or neurological changes that have life-threatening symptoms like seizures or stroke. The direct impact of the relationship of substance use on those long-term health conditions, that's very difficult to consistently and accurately capture for some sort of measurement. It slips through the cracks. They're not often quantified or tracked in that way. And so we don't have a number for what is the human toll there. But on the other hand, overdose deaths, while that is still nuanced and sometimes hard to detect, those are more readily discernible as being directly caused by substance use. And the latest CDC number of Kansas overdose deaths, and this was in 2023, is 615 people. Those deaths are occurring across the state, and they also are occurring relative to the population, to the size of the communities. So it's a pretty, static is the wrong word, but it's a pretty consistent number of folks. All of this has implication for the kinds of interventions and methods that you might select, and because those are the numbers we're really trying to decrease, right? Another thing to consider when you're determining strategy is the highly dynamic and the ever-changing landscape, the chaos, right, that is all around us. Case in point, we would be remiss if we did not mention the recent federal bill signed just a week ago today, which provides some cause for pause and some impact for us here. A research brief that was commissioned by the United Health Ministry Fund and the Reach Healthcare Foundations state that this bill does not explicitly reduce some of the partners the money for partners, like the mental health block grant or the substance abuse prevention and treatment block grant funding. We know the realities of that and the heightened pressure that the other losses in terms of funding are going to do, loss of Medicaid funding most particularly, really will place heightened pressure and an increase in the anticipated need of those resources. They go on to note that this bill does explicitly include those cuts to Medicaid that are likely to accelerate hospital shutdowns, and in particular, rural hospitals. This is something we have been tracking throughout the course of the study, and the citation that they had was really consistent with what is reported in the needs assessment. They report the threat for 63 Kansas rural hospitals that are considered at risk for closure right now, and they call out another 26 others whose status is really at immediate risk for shutting down. So there's a precarious time here ahead for our critical access hospitals. None of those implications are really supportive of healthy communities and are things that as a state we'll have to take a look at and work at. But another related consideration there is noted in the needs assessment that 29% of all Kansas substance use patients required some form of emergency or crisis service. So 26% of those who were seeking care or those who required care started in an emergent kind of a way. So as hospitals close, leaving people without nearby access to emergency care, there will be a shift, and that can be anticipated from crisis services being provided in a hospital emergency room to relying more heavily on things like mobile emergency response, as well as on the jails and the courts, who also deal with acute SUD crisis and serve people who are otherwise untreated. So this squeeze on the emergency and the crisis services also has potential to contribute to higher mortality rates, back to our goal of saving lives. All this to say, really, your objectives are spot on. Sustainable path for health and saving lives, and well-placed with respect to what the data is telling us. Yes. So we've been talking about things that we really don't control but need to be aware of. And I'm going to move aside here and let Zilka come and talk a little bit about some of the specific findings that we really can use to our advantage and leverage in action. So let me move out of the way.
Yeah. I'm Zilka van Esenwein. I'm an associate researcher senior at the Center of Public Partnerships and Research. And I'm a healthcare researcher by training, and I'm specialized in behavioral health. I'm really pleased to be here. You've talked to me, and I'm very excited about and very passionate about this topic. So I will try to refrain from laying too much on you, but I'll stay a little high level for now and then go more into details later. But one of the very big things that we found is that the use of medical detoxification and medications for opioid use disorder is very low to non-existent in the state, especially medical detoxification is really hard to come by in the state. Medications from opioid use disorders, only less than 5% of people get them in the state. And I'll go a little bit more in detail later. This is due to a number of reasons, is that there is very few trained providers, there's some restrictive prescribing rules, there's not a good treatment infrastructure in place in a lot of places, there's reimbursement issues, and there's stigma issues both in healthcare and in the recovery communities that keep people from seeking out a medical detox or MOUD. Also, it's supposed to be done in conjunction with mental health services and supportive services, and there's very few linkages to care that can provide that kind of comprehensive wraparound service to do MOUD right in the state. Also, and this is not the second finding, it's not a surprise to you, we know we have a severe provider shortage in the state and throughout the country. There's not a lot of behavioral health personnel, there's high burnout rates, there's some compensation issues. And so we have to find ways to boost the current and retain and boost the current workforce, but also pull in other providers that can become part of the SUD system that are not currently part of it. We really want to point out the role of peer specialists here. Kansas has a really burgeoning and exciting and passionate peer workforce, and there are ways to engage them more. We found that settings that had nurse practitioners had actually a 15% lower rate of suspected overdose incidents in the area. And so this is a group that we would like to talk a little bit about. We really need to talk about primary care and ER doctors. Those are traditionally been very difficult to engage in SUD services, and there are ways to engage them that we tell you about in the report, and I can talk about a little bit later. And I also want to talk about the pharmacies in the state. Almost all of the counties in the state have pharmacists. The pharmacists have talked to us, and they're very eager to go into that space. There have been legislative changes that enable them to, but right now the reimbursement isn't there for these services. And so that's another potential group of people that we can make part of the workforce that are currently not part of it. Another finding is linkages to care, to supportive programs and long-term recovery are relatively weak. We don't really see the existence of bridge clinics. We don't see a lot of mobile units in the community that can help people transition out of care and treatment positions into a setting that actually enables them to have successful long-term recovery. So you tend to have more of a treatment, go out in the community, fail again, go back into treatment, fail again, kind of recycling. And that's not very sustainable, and that's draining the system, and it's putting people's lives in danger. Another finding that we had is that actually commercial payers pay for most of the SUD services in the state. We did not know this before. And for us, this is really interesting because for us, this is a pathway to prevention and to sustaining the system. Right now, as the public system is getting more and more squeezed, we really want to make sure that as many people as possible stay insured and have access to services this way. And right now, private employers, insurers are not really engaged in the process, and they're not at the table when it comes to SUD prevention and recovery. We also know that a lot of the current SUD funding is relatively short-term, and that makes it really hard to build anything that's long-term. It also makes it hard to track outcomes. A lot of things take longer than a year to show an impact, so we would encourage you to think about longer-term planning. It's also clear that stigma is pervasive, and we're not talking only about external stigma in communities and healthcare settings, but also internal stigma. And that makes it really hard for providers to stay in the workforce. They face stigma themselves. But we also know that peer storytelling is a really effective way to reduce stigma. And so we want to talk a little bit about stigma reduction campaigns that include peers and other best practices that we know that work. We also want to point out that it's going to be essential to include youth in these stigma campaigns and include them in SUD programs. Traditionally and historically, we've been very, we're working on it, but I think getting the youth involved so they can talk to their peers and we don't use patronizing language when we talk about substance use is going to be essential. Any questions before we go into more detail? Okay, let's go into more detail. We're going to get more detail. Yeah. Mm-hmm.
We might as well just
Yeah.
we're twins here. Mm-hmm. Okay. All right, so taking action. There are some overarching process goals here, and you can see those that we've been keeping in mind. Pervasive, and we've talked to you about this before, is the fragmentation between and among the those who are working so hard to address these concerns. So we're really trained on what can we do about that fragmentation and the efficiencies and the effectiveness, the quality improvements that we might achieve by being a little more organized there. Increasing integrated care delivery capacity at a local level. That means multiple players, the behavioral health folks, the people who are helping to navigate the social systems, the emergency personnel and the medical personnel. The integration care delivery is really a best practice and something that we can increase. We are looking to ensure clinical integrity, so some of the I guess criteria for would we say, yeah, this would be a good place to spend your money or not, is really about whether or not the clinical work is being done in a way that is consistent with informed practice, with best practice, wherever we can. Does it save lives? That's another thing that we've been looking for. And then are we able to get some momentum, right? Can we quickly achieve some measurable impact and begin to see progress, which will help to keep and help to unify communities and professionals all around us and keep them engaged in what you want to achieve. So beginning with the end in mind, we started with the vision, and we did this right off the top. We crisscrossed the state, and we conducted 11 community visioning and strategic foresight sessions. We called it the Futures Tour, and we took all of the ideas and the input that came from that tour and organized it and tried to find meaning with that, and then provided it with our accountability cohort. And we asked them, what resonates with you? What does this mean in your experience and in your expertise? And through that dialogue, we started committing our ideas to paper. And then we used those words from participants along the 4-day Futures Tour, combined with the perspectives of people with lived experience, and we worked together to draft the intentions and the reflections for what we're doing, which now serves as a long-range vision with descriptive guiding tenets. What does that vision look like were it to happen, right? So that we can visualize where we're going. And then over the course of the project, we periodically, as we got more information, as things, we would learn new things, we would incorporate that and do the double check with the next groups on how to refine those collective thoughts. That process culminated in earlier this spring in a meeting of our cohort advisors and the Sunflower staff, and that's where we said, okay, we've got it. This is the vision that we would like to put forward, and these are the tenets, and you see those on page 4 of the associated materials today. Yeah. That particular process, that process of setting a bar, understanding that it's sitting there, and continuing to interrogate it, so to speak, as we go through the process, that is really important to making sure that that has meaning and really accurately reflects all of those voices that we're trying to bring to you. So the next step was to factor into our research regarding identified Kansas-specific strengths, gaps, and challenges, as well as where are the key levers for the potential opportunities that might address our issues. And that is articulated as 6 priority areas. And in the document itself, that can be found by just going to the bookmark settings and clicking on recommendations and priority areas. And there's quite a lot of detail there with regard to how that looks. So we start with the vision, we work to the tenets, we jump over the recommendation at that point, we go to our key priorities, and then we start looking at strategies and tactics. Let me pause where I am here. There are 3 priorities that fell squarely into the purview of community best managed. And 3 of the priorities that fell into a bucket that is best managed at a systemic or a systems level. And so priority 3 is to prioritize the prevention of drug use and drug-related overdoses and deaths. Priority 4 is to expand consistent statewide access to high-quality SUD services. Priority 5 is to normalize continuous care models that sustain progress beyond initial treatment. All of those are really individual and community level concerns and best managed at that area. Not out of sync with the systems, and we'll talk about clearly today with some specific, could go like this, it could go like that kinds of examples. How do we link the systems infrastructure perspectives and elevate the local and community-based kinds of needs? In the priorities. Priorities 1, 2, and 6 are all systems-based. And you have an opportunity here to really impact those systems as well as the individual work. So priority 1 is to develop structured relationships that foster community-driven health and well-being. Priority 2 is to reduce the stigma that Silke was talking about and expand statewide public knowledge and engagement. And priority 6 is to ensure long-term programmatic and financial sustainability. So we're back to sustainability and saving lives, right? We then went on to identify some specific strategies under which each of those priorities that could go under each of those priorities. And here are some of the questions that we asked ourselves when we were thinking through those strategies and how to consider them. What's in place now? What can we build on? Or what might inhibit progress? Okay, current state. Are there existing working models here or elsewhere that we might follow? What do people say they want? We think that that's important, particularly at the beginning of your work as we're trying to gain momentum and participation. Is the method proven or evidence informed? We're talking there about that quality and the integrity piece. What's the resource investment? And money, of course, time, expertise, those expenditures, what do we have? What is our currency for all of those resources? What is feasibly scalable? And what factors need to be in place in order for it to be sustainable? So the other thing is that as you do this, you've got many years to plan for. And so we really also looked at what are some of the timing factors. Like, yes, we could aspire to do this, but before that could happen or before we would actually flip that lever, this and this and this would also need to be in place. And so we were looking for those kinds of opportunities. So then when the groundwork is laid, it brings us to the question of what do we do? Okay, we've got all this data, we've got our measures, we've looked at it all. What do we do? And we heard that from you as well. So based on the data and the social nature of substance use disorders, we believe that creating long-term change is going to require a multifaceted approach. And we've been calling them like a suite of strategies, things that you purposely collect that address both those systems and those individual needs, the voicing and the leg power, the people power in the communities to bring to fruition. And we're not proposing, here's what we are not proposing. Some people are like, have been concerned and they voice those concerns when we talk to them. Well, you know, they start to lobby for their particular part of the pie. And we are not saying stop doing those kinds of things, stop considering those kinds of grants, so to speak, but also layer these things, and so that you can be working for the short term as well as the long term, and have been specific about some of the strategies that we put into the report and that we can speak to in order to do that layering. We think that's important. Okay. Silke.
I'd like to go through some of the priority areas we identified earlier and talk a little bit about what models exist out there, where it's working, other states, or even within Kansas. I'll start with MOUD. We've said that MOUD, especially when combined with behavioral health and support services, is really we know by far the best way to reduce loss of life and to have a good impact. Really no other treatment modality comes even close to saving lives. And the research is really solid on this, and we also know it's not happening a whole lot here in Kansas. So there's a few things that need to happen in order to do that. We need to expand the workforce that gets engaged in MOUD administration. Legally, that's really nothing stopping other workforce to step in. Including ER doctors, primary care, and others, but they have not really been engaged in it. We haven't really seen an uptick in prescriptions, for instance, from primary care, even after the appropriate laws were passed. There's also this untapped potential of the pharmacists. So let me talk a little bit about ER doctors. Buprenorphine initiation is one of the best ways to start people getting on it. Get people on MOUD. There's also mobile units that can be employed outside of ERs that can help with initiation of MOUD. But we've seen from other states, especially Oregon, what you really need is you need a physician to go in and talk to their peers and talk them through, here's what happens. You don't have to be afraid of it. It's relatively easy to do. You need the hands-on one-on-one contact to get buy-in from physicians to do this. The pharmacists, there's some really exciting things happening around the country. New Mexico is sort of the flagship in this. They've been allowing pharmacists to not only initiate and administer, but actually prescribe, do the prescriptions themselves. There's other states that are jumping on board with that too, including Idaho. And then there's numerous states that have found ways to have a physician supervise maybe the initiation and change medication, but have pharmacists actually administer it, and this includes Missouri and Colorado and others. So there are plenty of models out there that you could look into and see what can we use. It's really one of the most underused workforce resource in this state, we believe, and they want to get engaged. Also, what then, of course, needs to happen is you need to make these linkages to care, to behavioral health services. You actually get the wraparound service and the support services. And one of the things you'll see with all of these recommendations we're making is that whatever you do, you're addressing this fragmentation of the system, right? So whatever strategies you want to focus on, it's ultimately going to come down to you need to reduce the fragmentation and the efficiency of the system. Some of really cool mobile MOUD systems you could be looking at is Boston, Alaska, and New York City. We have one mobile MOUD unit here in the state, but one unit is not going to do it. And honestly, also, it's not supposed to stay mobile. Mobile units are supposed to be kind of getting into an area before you can set up a brick-and-mortar clinic. One thing that we think is going to be really crucial to alleviate kind of the fragmentation in the system and fixing the linkages to care issue here is invest more heavily in the co-responder model. So co-responders brings together behavioral health professionals with first responders. It could be law enforcement, EMT, or fire services. We've talked to lots of first responders who said that they can't afford to have a rig sit there for hours to convince somebody to come to the hospital if they don't want to come. And so if you have somebody with you that actually then is trained in talking to somebody, making sure they're stabilized, provide linkages to care. If they get transported to the hospital, they can provide follow-up. It's going to be really important. We looked at the transportation rates in Kansas of how many people actually get transported to the hospital after an overdose, and there are areas in the state where half of them refuse transport to a hospital. And so I think it's going to be really important to have invest into this co-responder model. Now, who is a co-responder can vary. That can be up to the local resources. It could be a peer. It could be paramedicine person. It could be trained police force. We have a couple of pilots of this in the state already, and they're very successful. We know that Johnson County is doing really well with those. We have a crisis intervention team in Johnson County that comes when 911 is called, that does this. And we know from around the country that it's really helping a lot. So for instance, in Tulsa, Oklahoma, they have a very nice data tracking system, and they were able to show that their 911 calls for overdoses dropped by 70%. So the cost savings there are very obvious, not to mention the life savings. For the systems coordination is, I think there is, right now, there's lots of good data being collected, but it's not coordinated across the system. And it makes it really hard to look at outcomes, and it makes it hard to look at what's working or not. I think a really good example of where it's working well is the data warehouse in South Carolina, and they've been doing this for a long time, where they collect all public sector data and others, so you can actually track people throughout the system. So if they go into the criminal justice system, what are the and they come out, what are the ripple effects on the other systems, on their families? So there's definitely some models out there that can help you look at how have other states made this work. I think the commercial payers are really an untapped strategy in the state. I mean, they are paying for most of the services in the state. We want to make sure that people stay employed and they stay insured and their treatment is covered. So we think that they need to be part of the systemic conversation. And I honestly have to share with you, they were the hardest ones to get to the table in our process. We think
Who was the hardest?
the private insurers, the employers. I mean, we bent over backwards. That was the hardest one to get to the table, honestly. And I think there's strategies from around the country that we talk about that can help them understand. And there are some companies that are really good about it. And so some of the lessons learned, they're very good. Locally, I would say Tyson Chicken has actually been kind of they're pretty open to mental health and substance use interventions in their factories. And so there are some champions that we can tap into.
Champions of employers or of
Mm-hmm. Both. I mean, it goes hand in hand, right?
you have examples, not
Yeah. No, but for instance, yeah.
statewide plus also across the nation.
Right. And some of these are in the report, but I think in Kansas, like Tyson Chicken stands out to us and being pretty involved with that. But Hewlett-Packard, there's others that, and they have shown very well, like investing in this saves you this much money. So they have the kind of arguments you can use to get people on board. But go ahead.
One of the things that the accountability cohort brought to our attention is the factual studies that people who are recovering from SUD make really excellent employees. These are people who are on time. These are people who want to be there. These are people who are really working hard and well. And so the statistics, whether you're talking about SHRM, the national HR people and others who are tracking those nationally are saying, yes, not only is this good from a business perspective, you have employees to work for you, but this is good from a community perspective, and this is good at an individual level as well. And so there are some myths, I guess, out there, and some work to dispel that. The other thing in terms of connecting and engaging with the managed care companies and with insurers is to focus on elements that are preventive with them. They are more receptive, generally speaking, at this point with that. And so there are ways to engage, but boy, we tried. That's why I said, say that out loud, because they're not big on even individual conversations. So,
I've had the same problem.
Yep. Yeah, I think we can strategize a little bit about, what would get them to the table. I think from a financial point of view, we know that it makes sense for them. We also know that like the best treatment and recovery programs and worldwide are actually the ones that like airlines and hospitals provide for the physicians, because these are high investment jobs, right? They can't afford to lose these high paying, high skill, and they can't risk people making mistakes either, right? So, and we know these programs work really well, but we also know they're expensive, but they can show that they're saving a lot of money, right? Like a penny spent always. But it's definitely, I think this group is going to be more important than ever to engage. Yeah.
Forgive me, this is just the way that I think. So I'm trying to go to the end game. And so we have been at this for a period of time now where we have been reactive. We've sent out grants that say, help us think through prevention or whatever it might be. And people apply for those grants. Now we have data and research that gives us very specific things, like you talked about the mobile MOE. So is it, and maybe this is a question for Sunflower, maybe it's for the board, I don't know the answer, but is our next step to identify these very specific things and send out requests for grants or requests for, can you fill this void for us? That's where I'm
Yes, and that's actually my next talking point. So there we go. So I think that you can have a lot of influence on the system by the way you structure your RFPs and how you give out your grants. After you pick what you want to do, what voids you want to fill, what you want to bolster, you can really think about what you require of grantees to have part of their programs. We would suggest you require them that has to be a cross-sector collaboration, that they have to collect measures that you can decide on. And usually what's done is a funder can say, here are the 10 measures you need, you can pick from, you have to pick 5 of those. Good baseline, good follow-up. Nothing happens without a good baseline, and we need to see what these action steps are to get there. And it has to, and they have to promise that they're going to share the data with you, and it's going to be shared in whatever way you want to collect it. But it is usually expected from a funder to say, here are the things you need to meet to be able to get money from us, and you can ask them to do cross-sector collaboration. You can tell them what sectors need to be at the table for certain things, right? Do you want to require them, you have healthcare, behavioral health, support services at the table. Who do they bring to the table? They can decide on the local level, right? Locally, people need to just and fill what they see as the gap and what they have there, right? They may not have a hospital that wants to play ball, right? You give them the flexibility locally, but you can set the structure and the parameters around what you want them to see in terms of doing the work that you want to do. This is how you connect the overall strategy with local flexibility. You set the strategy. This is what we want to do. These are the measures we want to see. These are the outcomes we want to see. And these are the players we want to see at the table. We've given you a lot of information in the report about what the best practices are, where things have to be in place, for instance, for MOUD, for it to be successful. And you can ask them to fulfill those criteria and report on those criteria. So absolutely. Does that answer your question?
Does to some degree. I guess the question becomes, we meet once a month, right? And we're all busy people. So this issue is such a big issue and there are so many moving facets to it. How do we prioritize where we're going to say, hey, I want you to do X, Y, and Z and send out that grant? And how do we prioritize that with the biggest bang for our buck?
I think, my opinion, over the next couple meetings, months, we'll as a board, decide those priorities, based on their findings and other just personal experience, because again, some of this is, put the carrot out there and we got, the funding is not a problem for us, and that's a pretty big carrot. But also, at the same time, the innovation part of it, because you're in the middle of it and part of organizations, and I think everybody on the board, realizes that we've just been doing this over and over and not changing anything. So part of it is that, yeah, we want, these findings, how do we get there? But part of it is the innovation of how to get there. And I think that's where this board will come into play, and knowing it, I don't know how to design an RFP that's kind of open-ended, but I'm sure there's a way to do that, because we might have 10 RFPs that are $5 million each, and if 3 of them are successful, I would consider that absolute success. And it's not like we're wasting money. So to your point, I think that's where we'll, or hopefully as a board, that's where we'll be doing our work over the next 2 or 3 months. And
You want to say something?
in an innovative way.
So for me today, the goal of this meeting then is to listen to this and then help clarify in each of our respective minds some level of prioritization, and we'll get together as a board at some juncture to do that.
Yeah. Soak in, there's a lot to soak in, and we won't, this will be the tip of the iceberg today, but at a high level, and then, CPPR is glad to be engaged, going forward and to share this information with us, plus other resources that we might have.
Yes, absolutely. And this research by nature and this big problem, as you acknowledged it, specifically, it's like the proverbial, layers of the onion. And so we're trying not to, there's 500 pages there. And so what we don't want to do is just stand up here and click through statistics. That makes it really hard to well, how do you put this all together? So what we're doing today is setting this, here's what's important. Begin with the end in mind. Here's the vision. Here's where we want. We've affirmed your intuitive direction, with the data, right? So yes, what we want to do is be sustainable and save lives in the short term, and what are the best ways to do that? And that this notion about the interaction between what's happening at the community level, there is also incubators all over this state. There are people doing really creative things that will fit underneath a more global strategy. So like Silke said, you all set that strategy, and you all say, this is, you bring up the level of what you get by saying, here are the measures that we'll all be looking at together, and we'll be putting that out there. And not to be underestimated in this whole process is the importance of bringing all those eager people along with you. So there's a whole section here on community engagement and the systems infrastructure. And so here we're talking about, we're going to expect and we're going to put this challenge out to you, community, but we are also going to be here. We're going to be here with purposeful kind of collaborative skill building. How do we bring those grantees and others in the state together and more accustomed to the conversations that they can have? Specific work groups, where would we seed work groups that we know that we want to involve people? Some people use work groups for those who aren't grantees, and getting so that they, as a board or as an organization, remain alert and aware about the whole big picture as you are also supporting and moving ahead with those in your specific grants. Technical assistance is there. a regular cadence of communications. We found that really important in this process, and I think it will be important going forward. You know, this is important, very important. And within that is this broad and specific campaign that helps to also soften those edges at the community level. There is, when we say stigma is pervasive, you see it, we see it, everybody affirmed that. We really do need a broad and specific campaign. Zilka talked about it, bringing in the real stories. These are our neighbors, right? These are our family members. This is what's important, and some themes that would help there are things like substance use is a chronic illness. Like, let's recast what we're talking about here, right? This is not a moral failing. This is not all of those things that feed into the negative stigma. But here's what it is, and we can tell those stories because it is what it is, right? We can attribute attributes of recovery-friendly communities. This is what you get, community members, right? This is the importance to us. What does community mean? And the benefits of living in recovery-friendly and communities. People will hear that. People will want to know, what can I do? That might be something that you put in your RFAs for communities to consider. If your community wants to play a role here, what role would you have them play in your initiative? Right? The more we can break down those barriers and bring people together, the faster I think that we see progress.
I want to point out one really great example of community engagement and stigma reduction. There's this small rural county in Idaho called Klamath County. And they used $12,000 and they launched an incredible anti-stigma campaign in their community. And that included training and paying barbers and hairdressers to be mental health go-tos. They have stickers, you know, it's called Hair Talk. So if somebody starts talking and the hairdresser feels like they're having an issue, they can actually take them aside and talk to them and they get paid for it. They have video contests with youth, which are incredible. They're some of the best anti-stigma videos I've ever seen. They had one very important, they had a real high suicide rate among men in the county. They had peer-led campaign aimed at men. They have very popular coasters that they bring to the local bars that people love. They're funny, and they cannot make enough of them. People love them. And so with very little money, but with good community input, you get people, I mean, getting the hairdressers and the barbers, other places use dentists, right? Everybody's kind of an access point. You can really go a long way. And you make it local. I mean, the messages that they used in this county resonated because it was people from there creating the messages and talking to people like they want to. And, we talked a fair amount about people saying, we feel like we don't matter. And actually the pocket cards that Klamath County uses says, you matter to Klamath County on one side. And people loved it. And so there's definitely examples out there on how you can do it well. I think there's also research on it. So the Healing Community Studies has a whole set of, here are the things that you need to put in place to launch a successful anti-stigma campaign in a community. And I also want to say there's free training and resources and toolboxes available anywhere. The Opioid Response Network, that's free training on, you want to put a Narcan box into your community, here are the things you need to do to get the community ready to accept it. And we listed all these toolboxes and resources, and lots of them are free in our report. One thing I want to go back to is for the funding and innovation. I do think that you want to shift most of your funding to long-term, let's say 80%, but you do want to retain some short-term funding so people can try new stuff out. You have to give people, we call that freedom to fail forward, right? And so sometimes you don't necessarily want to give them $5 million to try something out. That's going to be, you're going to be risk averse for that, right? But what if somebody has some idea that's completely out of the box? I think you should retain some portion that can be a one-year funding, just if somebody wants to try something completely unusual and see if it's working or not. So I think a nice mix of evidence-based, we know this is working, let's do a big pilot somewhere, and some smaller, innovative funding would be might be something you might want to consider.
That's right.
I think you've taken all my other talking points, so.
I think it would be, I'm really mixing it up here. But I think that it would be helpful in this quest for how can everybody help you to do these things? You have resources, and so you can incent these activities and support them and have what people often don't have. But what they know is their communities. And then we got to thinking, but do they? Like, do they know their communities about what's contributing to the substance use here? And what level of detail might they need? And so that's when we started looking and created with, it's unique to Kansas, this substance use risk and resilience index. That's this piece. And this is good for you, but it's even better for the communities. And we went by county because it was really the cleanest way to go. But created this index that is descriptive, if not predictive, of key risks and protective factors by county. And then once we saw that, we applied that to each of the counties and came up with a scale here, a vulnerability level. And that's what you see at the top there, the very low to the very high vulnerability. And you can see at the bottom of that page, okay, if I happen to pick up the Ford County piece, and Ford County is at a high vulnerability level, who else is there with us? And they're at the bottom of the page. These are others. Now, that doesn't mean they have the exact same risk factors, but that means they're in a similar tone, a similar environment, right? And that means they might be somebody we might want to collaborate with. That means they might be doing something that we've not tried yet. Those might be connections that would really be helpful. And so that's when we decided, okay, then we need to get this information out in a way that people can at first understand us. Where are we in our community? And what does that mean? And what does that look like? And have those community conversations. And so the tool is to look at these, how many drivers? 18?
So we actually, we determined what the 17 most predictive factors were for substance use, suspected overdose, and we included those in the sheet. I mean, we looked at almost 50, variables, but these are the ones that came out to be the most predictive when it came to suspected overdose rates.
Right.
And those were gleaned from
our data.
Wide or statewide?
From the state data. So this is we collected over 70 quantitative data points, and then this is we created this combined database. We ran the analyses, and we first narrowed it down to 47 variables that were associated in our statistical model with substance use overdose. And then we want to really get technical here, then we did what's called a lasso analysis, where we look at which ones were the most predictive ones. And those 17 that we included here are the most predictive ones when it came to substance use. And I want to make sure to show it, these are not only risk factors, these are also protective factors. Right? Because when it comes to preventing substance use and substance use overdose, you can either work on the ones that are risk factors, or you can bolster the ones that protect people. right? And so we included the 17 that were the most pertinent ones. I also want to say, like, these vulnerability clusters would also be an option. For instance, get people in one room, have a work group, have a collaborative. Because even though they're in the same risk group, they might have very different profiles. But they can look at their own profiles and see where are they different, what are they doing differently, what have they tried. It gives an opportunity for people to work beyond kind of necessarily the geographic neighbors and look at maybe like the vulnerability and protective factor neighbors.
I'm not very smart, so I think I'm hearing you say you're looking at the 17. Say that again.
So the 17 variables we included in these county profiles.
What are those 17?
Here, that's listed here.
Okay.
Yeah.
And this is where I'm not very smart.
Yes,
Okay.
well, this is
21 listed.
Oh, that's 21 listed? Okay, then maybe include it more. That's my mistake.
Make sure I wasn't missing something.
No, that's my mistake. We probably, I think we included some descriptive ones. Yeah.
Thanks, I just needed to clarify.
Yes, yeah. So these are the ones that, so we wanted people, what we heard over and over again is we have a really hard time getting to our data. I'm in this county, I work for this health department, I'm applying for the grant, and I'm having a really hard time finding our data and how we compare. And in my mind, for these, I want to give this to somebody and say, here are the data that you have in hand. We give them the references that they can use to say, this is where the data is coming from. We explain where it's coming from and what it means. So for me, this is a grant writing tool.
Yeah.
And so, but it's not only that, right?
It's a conversation tool.
Right.
As well, so.
I'm sorry, can I ask a question before you?
Yeah.
I'm not going to acknowledge that I'm not very smart. You just said that like being recorded, so. This is really cool. I mean, thinking about grant writing, I'm looking at Krista about DECA grant writing years ago. Gosh, where was this, right? So is this something, thinking about utilization of this information going forward, is this a technology that, things might change from 2022 and this is readily available from Kansas Health Matters in 2025? I mean, is this like a click button and all this stuff populates, or you have to go back and look at it?
We'd have to go back.
We'd have to look at it because the key to it is how it all integrates together. So what you have here, let me just walk through what you have here. So you have, who am I? Ford County, okay? And where do we fall at the macro level? At high risk. What does that mean? So predictors or drivers of substance use, and you see that first section. And I can see that, 19% of adults are diagnosed with depression in my county, and that compares like almost 1-to-1 with the state level. And so you have that ability to compare. You also have the ability to find more friends. Everywhere we're doing this, we're looking for how do you draw people and how do you help them to come together, right? Then you go to the data measures, because a lot of us aren't very smart people. And I rely on my colleagues. So now I can look at the data measure, and I can, here's what this is describing. Like there's a little extra, what are we looking at here? So I can understand it, and then the data source, that's a citation of these sources, okay? And then we say, okay, now you understand your profile, right? So now that you understand your profile, look at the priority indicators, and together with your community, let's decide what are we gonna tackle here? What's the first step for us? They can do a lot of your legwork. You cannot, from this position, understand 105 counties and all, so that they can help us there. We encourage them, look at this, just like Zilka said, for your strengths, as well as like, what are the problems? What are you going to use to help leverage and give you energy and lift? And then how to engage partners in community who would be a part of that conversation, and we suggest that for people there. So this was a tool that was developed and is intended for dissemination on the website so that people can readily see what's up.
Okay, just let me clarify my question.
Yes.
Thanks for all that, that's helpful. So,
Didn't answer, sorry.
okay, if I'm writing a grant in 2029, the technology's not available to say, here are all the factors. I can just click a button and it's going to repopulate with updated information from all those sources.
It would require us to go in and put in more updated.
Thank you.
Yeah, we would have to like
So this is
repurchase.
a point in time, this is a point in time.
Yes.
Always, always. I mean, some of them are just looking through them, some of them, they're going to be updated, but a lot of it is from data that we bought, and that's going to be outdated, right? So definitely, this is a point in time.
It could be something that you do
Yeah.
as a group. You could say, okay, we're going to contact all of those and we're going to contract with them to provide us annual data. And then, but then you also need the, how does it come all together? So,
Well, that's what I was thinking, is that we could, if this is a very useful tool, then, well, nothing would prohibit us from funding it being updated every semi-annually, or I'm not a technology guy, but there's probably a way to have everything point into this to where it would be a click of the button.
So when you think about, we're not talking about just today, we're talking about through 2038-ish, right? And data sources change. I mean, the struggle in communities is understanding what's happening in your community all the time and how things change. And we've also been in these conversations about data repositories and how do you share data. And this is an amazing tool that can benefit communities and people writing grants. And so I would want us to put in the back of our heads, is this the value, one value that this board brings to the state, is kind of having this type of data repository on a regular basis and updated. I just think that's a cool thing.
Well, I will share also, I don't know if anyone's seen this, but our grants manager position at Sunflower recently came open, and we hired DJ Gehring for that role. And so we have someone with EPI level experience on the team that maybe this would be feasible now.
So you said there were 50 measures, and these 20 plus were the most predictive. So how will we know if 7 years from now, it's a different set of predictors?
You would run the analysis again.
Just have to
Yeah, yeah. I mean, definitely want to reevaluate. Yeah, I mean, you always want to start with like all the ones you could possibly think of, right? And then run a regression analysis to see which ones are contenders, and then you do another analysis to see which ones are the most predictive, yeah. And you would want, I mean, you don't change that quickly, right? But you definitely would want to rerun that analysis to make sure if there's something that changed, right?
I'm just thinking for our board, we need to think beyond just these, because we might pull new ones in next year. And then my second thought is, this is really good information because every county got money too. So how do we connect all, like Sedgwick County is in the process right now of figuring out how to spend their 15 million. But they need to know this.
Robin, I can answer that question. As soon as I have access to each of these documents, I'm sending them to the subdivisions who are participating. So they will each have these in hand.
Getting back to the
It's on the Sunflower.
overall strategy of collaboration. And so if, I hope, it's one man's opinion, is that whatever strategies we develop, that we're not the only funder. And we know most every city and county, they could participate at some level, hopefully, and there's lots of other.
Yeah, and we talked at the municipalities conference, and it was clear from the panels that we saw there that, especially the smaller counties that only got small amounts of money, and they're like, we don't know what would I do with $10,000, right? That the ones that used it successfully, the ones that said, oh, let's partner with 3 or 4 other counties, and let's do something together. And I think that is going to be a nice motivating factor. So like, you don't have to do this on your own. Oh, sure. Yeah, no, definitely. I mean, this is not the only project where we hear that people talk, people are like, I'm the only public health person in my county, and I'm writing all these grants, and I can't find any data, and it's really frustrating. And so, and these are SUD specific. right? As the Kansas Health Institute has the ones that they base on the county health rankings, and those are super helpful. But between those two, you really have all you need to write a good grant.
Mr. Chair, do you mind if I ask a couple technical questions that I'm certain I'm going to get asked by the municipalities? So just trying to understand how the terms here. Percent of needed naloxone units that was distributed, how was needed calculated?
If you go to that page, so we base that on, need is based on NISTA data for that county and treatment data. And so we have a calculation when we look at need overall with treatment and then have an unmet need.
Okay,
Yeah.
so specifically for naloxone units, it was based on like SUD, or it was overdoses or SUD diagnoses?
No, for overdose, there we look at overdoses.
Okay.
Right.
Then,
Suspected overdose.
gotcha. All substances, okay.
You can't, unfortunately, you can't tease out opioid itself.
Sure.
But all overdoses. Mhm.
And that's similar for needed fentanyl test strips, right? Okay. Then one question just on percent of people with an SUD diagnosis not receiving services. The number seems quite high, and I was reading through other sources that it's in part because people they don't believe they need.
Absolutely.
Is that right? Okay. So was there a factor that you looked at there, just so that I can answer this question, of people who identified they needed services but were not able to get them?
We can't really establish that. It would be really lovely.
Yes, okay, gotcha. So then, one other question here is, number of providers with MOUD-related claims in 2023. I just noted that the IQVIA data was from 21 to 23 rather than 23, which was for the other IQVIA sources. What was the distinction there?
It's just the availability of data.
Gotcha, okay.
But we looked at so if they had any kind of claims, and now these claims include private, Medicaid, Medicare, VA, and we looked at block grant data to follow that in, but if they had any kind of claim whatsoever for MOUD, then we said, okay, there's somebody who provides those services there.
Gotcha.
Just to piggyback on that, because I caught the needed too, and it
Actually, can I see
just
that?
one of those words that bothers me, because that would imply that there's unneeded naloxone being distributed. Because if you have one, you have to have the other, and I think, well, that's odd. And I know that's not the intent.
No,
just
no, that's just,
kind of reads that way. And so, but to move to the percentage of people with an SUD diagnosis who are not receiving services, that's strictly based on a claim being made where a qualified individual who can diagnose substance use put that into the claim. Yes? And then there's no follow-up service. For substance use, I mean.
well, yes, so all the data we got for IQVIA had people that had an SUD, behavioral health diagnosis.
So I have two questions. One, the methodology for adults diagnosed with depression is not based on claim. It's based on,
And diagnostic criteria.
no, well, adults who report being told by a health professional that they have depression. Is there a reason that we looked at that in two different methodologies?
Because that's the data that was accessible, and depression is so
Okay,
Yeah.
okay. No, that's helpful to know. I just needed that distinction.
why.
Because I look at this kind of apples to apples, and it's not apples to apples.
No, no.
not.
So actually, if you really want to deep dive on it, like you can go to the appendix has the methodology and all our calculations in it, so you can really see, we can actually tell you by diagnosis code, by billing code, what we
And I'm really
included
more
where.
just
Yeah.
curious as to the why
Yeah.
that was the route for each of those two different diagnoses.
Well, yeah, because you've got this whole realm of data that's telling us one thing, and then we have to look at, okay, what would be the significant indicator of that? And the availability of data for those different significant indicators varies by.
Yeah.
Right.
And the questions that they ask and what they include and how they define it might very well be different.
Mr. Chair.
that if that was based on claims data from pharmacies for antidepressants prescribed, it would be closer to 50% to 75%.
Yeah, this one actually came from the population level and also community places.
I saw that and I thought 20% is very low.
Yes.
Yeah, no, I think with all of these, like even looking at the NISTA data, NISTA doesn't include people that are unhoused or incarcerated, so it's probably an underestimate too, right? Like, so each data has its,
Good and bad.
yeah, limitations, so. But if you're writing a grant though, you say, that's a lot of people. At least, you say at least, at least a fifth of everybody in this county.
The line of questioning kind of underlies one of the biggest
Right.
challenges is that, self-diagnosis doesn't work very well in the physical health, but yet in the mental health and substance use, we don't have a blood test or, an objective type of test to tell somebody and then you put in the stigma side of it. I'm not going to self-diagnose. I got to be pretty bad, which I was, to say, okay, I'm an addict.
And the provider needs to.
There's a lot of people around me that thought I was. They were right, but I wasn't going to raise my hand, and that's what we find all the time working out in the field.
Yes.
Monica?
Hey, thanks, Mr. Chair. Hi, everybody. And sorry if this question is asked, but I'm flying along the southern border of Kansas, and sometimes I hear and sometimes I don't. So first of all, I'd like to go back to Sandra's comment and Robin's. I think the bigger thing that I've been in here is that this data source is a moment in time, and it is fantastic. And it is something that we can use for so many different purposes. So I'd just like for us to keep it out front of us as a board. How do we build upon this? And of course, it'll involve different, contracts, different money. I heard what Krista said about DJ, and I'm like, okay, now. So I'd really like for us to just kind of keep in mind that this could be a long-term investment of the continuation of this, dashboard system, whatever we want to call it. And it would save local folks so much time and effort. So thanks for that, Mr. Chair.
Thank you. Other questions or comments?
Yeah, Mr. Chair, just one more kind of, two more technical questions. I'm an attorney. I know I shouldn't say just one more, but so on the technical side of things, the very high vulnerable counties, I'm noticing it's not exact, but it looks like population is also a driving factor. Is vulnerability tied to population size of the county, or is that a very good predictor?
No, they're all population adjusted.
Okay, very good. And then the vulnerable.
Having said that, of course, indirectly though, right? Of course, if you depending on, there's different resources, there's different drivers, there's different population demographics. So of course, there are population, but it's not the population density per se.
Gotcha. No, I appreciate that. I was just looking at this, like, I've got Wyandotte, I've got Shawnee, I've got Sedgwick. The only one of the top 5 population I don't have on here is Johnson County. So that was what I was.
On the table.
Sorry, in the very high list.
Okay.
Right. Because they're not all the same, right? It's not as easy to say, oh, it's an urban issue.
Yep.
Right, because I think the last time we were here, we showed you like the top 10 suspected overdose counties. Yeah, the top 2 or 3 are kind of your usual suspects, but then you really quickly get into rural and frontier counties, right? So it's one of the factors, for sure.
The other question that I know I'm going to get asked is this vulnerability level. Is that a judgment call, or did you have thresholds that set, like, you had 86% of people, and that pushed you closer to very high versus 84%, which maybe just dropped you down to high?
Yes. Do I know them offhand? No.
Very good. Okay. No, I just wanted to see.
Yeah.
Okay.
And if you look in the report, it's actually, we show you what the cutoff levels are and where the, if people can see how close they are, right?
Can I show you another cool tool? This is fun. And I wish that we could like put this up and do this real time. We will do that. We're waiting for, it's the IQVIA process of saying, yes, go ahead, we can put our data out there like that. So let me speak to this. That is a data visualization tool. It's created on a platform called ArcGIS. And it's these, okay? And what this tool is ways to be able to very quickly see and compare. So as you're making decisions, you can toggle back and forth and see what you need to see. And I want to tell you about how it's organized and the type of information that is in that. And then we will come back at a time that is convenient for you and actually walk it through, give it to you to play with, and then walk it through as well. It's, I learn better when I'm messing around on it. And so we want to provide that to you as well.
So if you don't mind, just for the people playing along at home, these are mapping tool that we can use to apply different layers to the map to get visual depictions of the information, correct?
Correct.
Some information, yeah.
So the
Monica,
information.
again, confirming, Mr. Chair, it's Monica.
Mr. Chair has stepped out for the moment. Monica, go ahead.
Hey, thank you, Chris. Thanks for showing some leadership there. I want to follow up on your question, and maybe too technical at this point. We own this, right? We will own these maps. We will own this interactiveness.
You own the ability to use them. They are an intellectual property of the university.
But you have full access to them.
Right. Mm-hmm. Monica, are you there?
I'm there. Thank you. And confirming that's for.
Right. Okay. We can follow up. We can follow up, or she may get to the top of the hill or something and call us back. So we organized the information here and selected the information here, let me say that, based on what we thought was going to be most needed to understand, to do a wide variety of things, to set RFA kinds of parameters, to support people, and to just have it at a glance. This is also accurate as of the 30th of April in 2025. So, you know, it also would need tending. The main categories here is just basically an overview of substance use across the top, the vulnerability to risk, which correlates very closely in an electronic form with the county profiles that we've just been talking about. Treatment and services, and then workforce. This is where I need to fire up, I think, but we'll see here. This first map is, all of those dots are critical access hospitals, and the size of the dot is the number of beds, indicative of the number of beds and where they are now, because we thought it was going to be important to be keeping track of what's where and what the resources are. And then simply basically I need to get to my script too. The 6 health counties, right?
Health regions.
Health regions, right. Then you can go to overdose. And if you go to overdose, I'm looking now on that bottom line, and this will be the gist of it today, and then we'll be able to walk through it in the detail after you've had a chance to also look at it individually. But if you go to overdose, then there are multiple factors that hit on that. And so I clicked on student substance use, right? And that told us here, see if she put that in the right order. Hold on. Down the side is the legend. You would click on the specific thing that you want to know about overdose, and the information would come up. You can click on the map legend, and it'll show you the scale. What does that mean? The different colors. And then when you click on the counties, you get a full view of everything that's in that particular layer, correct. And so you can see where each county stands. When you go through those, for example, here we're looking at student substance use in McPherson County. And we know that the percent of students that vape, that, you know, so it's by substance, and then an overall tally. It's at the bottom of the scroll, so there are a couple of initials. It's the alcohol components that you can't see on the screenshot there. But when we're talking about public communications, when we're talking about risk levels, when we're talking about, this would be important also at the local level as well as at the systems level, to be able to look and see by specific area or by the state overall. There are a couple more examples here. So we moved to vulnerability to risk. And Zilka mentioned this, and it's really worth noting. There is statistical information that shows that substance use overdose deaths go down with the presence of nurse practitioners, relative to the presence of nurse practitioners in that community. And so that was a particularly important thing that we thought to put in there, which was, okay, if we have access to nurse practitioners, and we know that that helps, who has what level of access? And you're able to tell that. And hidden behind that map legend is a variety of various professionals, so behavioral health providers and nurse practitioners and others that help us to understand the health of a specific community.
Say that again about the nurse practitioners, there's a direct correlation.
There is. Yep. So, yeah, so presence of
population.
Yeah, so that's actually a 15% drop in suspected overdose rates with the presence of nurse practitioners. Now, I can't say what's driving that difference, but that's an interesting one, a follow-up to do, see like what is it about that indicator that indicates it, right?
Curious, was it different between nurse practitioners compared to other like mental health professionals?
Mm-hmm.
It was.
Mm-hmm. So we looked at all of the different, we looked at MDs, addiction, all of that. We looked at the whole range that they had access to, and the nurse practitioners really stood out.
The other indicator, along with the nurse practitioners, and a real reason to have part of the focus be in this primary care realm, is that somebody referenced in their questions how primary care physicians are seeing people in their offices like this day in and day out. That's correct. But they're not writing prescriptions for them, and they're not diagnosing them.
They're not screening.
And they are reluctant to participate. I would put them number 2 on the, would put, the closed for lunch shingle out when we would call. So they are hard to get a hold of. The hospitals have good connection with primary care physicians. There are ways to reach them that we are simply not tapping right now, but that relationship, there was a correlation between people who reported that they went to their physician at least annually. Once a year was the criteria, sometimes more, of course. And those people had lower incidence of emergent kinds of experiences and higher incidence of getting help when they needed it. And it was because, again, you're in that, it was thought to be because, yeah, it's not our survey, but that relationship is so important. And that stigma isn't present when it's just you and somebody that you know and trust. And so, yeah, like, I look at it and I'm like, well, duh. But that means we really need to you would get high impact relatively quickly by bringing more of that into the SUD world.
I mean, we don't know what it is about them, right? I want to be very careful. This is a correlation. But I have some hypotheses why this might be. I think we also do work for the Kansas Connecting Communities Project, which trains clinicians in mental health and substance use needs of women in the perinatal period. And we've trained over 1,000 practitioners throughout Kansas right now, and it's much easier to get the nurses at the table. I think there is something to be, that's my hypothesis, saying I do think there is something about the quality of the relationship and the clinical practice. They have more time, they might have more time, a different approach. Yeah.
I'm just throwing this out there, maybe I have data and I'll follow up with you know, some other time or as a committee, but my experience, I've worked with a lot of physical health professionals that are both suffering from the disease and, you know, through, you know, of course, their standards are way up here, which we all want them to be, but my one man's opinion is that stigma maybe plays
very much so
with that cohort as anything. And from that, it affects. We tried to develop a plan. You know, we thought just what you were saying. The Jeep, you know, you're a general practitioner. You probably have a better, more trustful relationship than maybe even your minister or something. You know, you just trust them, go in there and get your physical. You tell them anything and everything, except when you get here, and I don't think they're welcoming. My own, you know, you go down and fill out your stuff for your annual physical, and I said, you know, you don't have any mental health questions, especially substance use questions on there. You know, why don't you ask me? I'm forthright, you know, and then I come back the next year, oh yeah, that's a good idea. Next year, you know.
There are some quotes even in the needs assessment itself from physicians who did talk to us who are really frustrated with that timidness, I guess, of some, or kind of the one physician was kind of a bragging kind of a thing, like that's not in my practice, you know, that's not how my patients are, and like they're rating themselves against whatever, and how their peers who get this or who are on the line for substance use kinds of things every day are frustrated with that, and would potentially be good levers. Zilka talked about the importance of that one-on-one connection in order to getting the ER doctors comfortable with what they needed to be able to prescribe, and you know, maybe that's a model that we need to start thinking about. How do we pair doctors with doctors? Or there's a lot of hints in all of these. You
probably ran across some.
Yes.
That were forthright.
Absolutely.
Yes.
Hearing and bring, you know, 5 docs in here and let them discuss, you know, ways that they think they could get the word out, or why they feel differently about it than maybe the majority, because I feel like that is a big thing for making a difference.
And also, you also might want to look at medical education in terms of what people learn what's in their curriculum. Like one of the kind of innovations we've seen in one of the nursing schools in Kansas is they, as part of the curriculum, they sent them to AA meetings to sit in for like a semester. And I think that's really effective, right?
Do you have a best practice site for how to get ER doctors involved? Because ER doctors, I mean, my experience with them over 30 years is, well, I may never see this patient again, so I don't want to prescribe because I can't follow up on what I've recommended.
Right.
So a best practice would be great.
And it's, I know I've included that in the thing, and the thing is that we can pull that for you. Also, they do see them again, right? The whole thing is they see them over and over again.
Right.
Right, yeah, yeah.
And oftentimes the group practice, ER practice may see
True.
it. A specific doctor may not see it.
Right, that's true.
So I'm curious about something when it comes to this conversation. I think it's a really good conversation about docs and their influence and those kinds of things. They don't get a lot of kudos for talking about substance use when they're going through the residencies and any of those things. They're on it. But at the same time, one of the things that stuck out with me in this report and in the county data that I'm looking at is the NSDUH SAMHSA piece, which I would be remiss in saying that I'm a fan of it because I'm not. I think it is a report that does more to promote stigma in the system than not. And I think we have to be careful because if I read this and I read the executive summary and on the front page we say almost 25 people in America have substance use disorder based on survey data, which is wholly inaccurate in my opinion. This is one of my problems. And then we go on to say, they don't want help anyway. So I think we have to be careful when we step up because that's what people read. And doctors, and I've talked to plenty of them, and why would I bother? They don't want help and they're not going to do anything anyway. And it kind of speaks to the, well, I'm not going to see them again, so why would I prescribe something? It's one of those things that stuck out with me when I read this is right up front, we say, and they don't even want help, which one of the biggest complaints that people who are in recovery, have been through treatment, have of those people like me is that I continue to tell them what they need. And I continue to tell them that they need treatment. I know more people than not that never went to treatment, and they're in long-term recovery. And the reason they didn't go to treatment is because nobody asked them what they wanted. And we don't teach doctors to ask people what they want when it comes to that. And we have some pretty strong statements right up front based on a study that is basing a lot of its work on the fact that people don't know what they need, and we need to tell them. And it's just, it's, as you say, I appreciate it, it's just one man's opinion, but I think we have to be careful with that.
So I think people do know what to do for themselves.
90% of the time they do. This is a misleading statistic because I rarely talk to somebody who is in long-term recovery that didn't know they needed help. They just weren't ready to go do it.
Yeah, and that's also this I think for me, like if you look through the NISTA questions, I think it's so normalized, right? Some of the questions are, if you're working, like you're looking forward to your beer at the end of the day kind of thing, right? And it's so normalized in our culture that a lot of it might be stigma. A lot of it is that it's so normal to use substances to relax and to go get through your life, right? That they might not say, I have a problem, because everybody around me is doing things. You have this whole wine mom culture, right? You have this whole Dad used to come home every evening and have a drink first and stuff, right? And so that's part of it too.
I would never dispute that number if it was put together with substance misuse. When it's put together with substance use disorder, which is a medical diagnosis, that's where my issue comes in. Because I completely agree with everything you just said, and that misuse is rampant.
Yeah.
But we're saying you have a disorder where these people, almost 25% of the people these doctors see have a disorder, and they don't even know they need treatment. They don't need treatment. They need support, but this is just.
Yeah, no, one of the things that I would have liked to have done is, so NISTA actually has different levels of severity. They have 3 different, and you can't get that on a state level, right? And so it would have been nice for me, ideally, I would have liked to know of those people, those are the ones that they should watch it, right? So maybe not interfering with their day-to-day life. And then there's the ones that they're in real trouble, right? And that was one of my frustrations. But I think it's worth, in terms of prevention, it's worth to note that it's even at such a relatively low, you have to say yes to 2 of the questions, and the questions are pretty, most people would say yes to, at some point in their life, a couple of those. I think that's where the prevention comes in, right? Because there's a lot of people that could potentially slide into having a bigger problem and really have a problem interferes with their life. And so let's not underestimate kind of the potential of how much prevention and anti-stigma campaigns can reach, right?
Absolutely. You're speaking the right language, absolutely. I think where I'm coming down to it is when you start with the stigma, it's hard to do the prevention. And just some of the things, some of the things that study said.
Right. Oh, absolutely.
I want to go back to the physician conversation. I have learned a lot in the past 3.5 years working at LMH Health with doctors. And Rob and I have such empathy for your 30 years of service. And I think it's important, what I've learned, it's important to understand the why of perceived resistance. And we have implemented the collaborative care model since October, which is great and has great outcomes. And there's been perceived resistance. And so as we talk about the why at LMH, it's not, sometimes it's stigma, yes, sometimes it's fear, sometimes it's, I don't want to know something because then I have an obligation to do something, and if I don't know what to do or who to call, then I'm opening a door I can't close. But I think the other real why, as we think about how we move forward with these initiatives, is the volume of expectation on medical providers. I mean, when I listen, to them about work RVUs, which I didn't know anything about like 3 years ago, financial obligations, I mean, just the volume of things that they're expected to do and see patients for 10 minutes, adding one more thing, even, because you and I have talked about this, Silke, even screening for substance use in a primary care setting. We'll add one more thing, like, how are we going to do that? So I think when we talk about these things, I want us to come from a place of not judging why they are or are not doing it, and really understanding the why, and it might be different in different locations. Yep. To me, this is the area of opportunity, just again, based on my own experience. This is the area of opportunity outside of the normal to really have an impact. But how we do that with physician and provider engagement is going to be really, really critical. Because if we say, you could do this, you could, I mean, we've been doing fentanyl test strips, and even that was like, oh my God, one more thing, what do I do with this? So I think that's really important to get their engagement early on.
And I completely agree, and I think I can tell you from our training experience for the Kansas Connecting Communities, like, how do you fit into your workflow? How do you facilitate, I have to fill out 1,000 forms, I have to ask 1,000 questions, I can't do another thing. How do you actually work it into so it works for physicians? It doesn't have to be at every time, right? Like, how does it fit into their workflow so it makes sense? And very importantly, actually, we talked to a lot of physicians that said, it takes me a while to build enough trust with that patient to be able to ask those questions and feel reasonably certain they're going to give me an honest answer. So a lot of it's about what are the signals so they're ready for that question and things like that.
And I think it also is the workforce in the ER. Because long ago at Wesley, I put social workers in the ER. Because they have the time and more expertise and more comfort level than the ER doctor does. Because the ER doctor's got to have expert knowledge on an enormous array of things. So it's helping hospitals at all levels have the appropriate people in the ER to identify who those people are.
Yeah, that's what I had two things. One was that I was thinking more in a primary care setting where there is a lot we have found in terms of parallels between substance use and domestic abuse, in terms of how our communities receive that and how we can relieve the pressure on our law enforcement, who has to talk about people who have to be experts on everything. That's that. But one of, you go to the doctor now, and it will be whoever is doing that initial check, why are you here today, and all of that, not the doctor at all. And do you feel safe at home? So what is the question that we might ask, or that others can pitch in to do, that would help to feed that into the medical realm, I think would be important. This is also a bright spot for Kansas, I have to say, because there is, in residency programs now, much more emphasis and requirements for physicians to learn the SBIRT tool and that evaluation. And there was another piece, that they were also learning technical kinds of things starting at the residency level. And that is beginning that normalization of this is a chronic disease. This is something we all need to know about. This is, and it's a generational opportunity.
Yeah, and I have to say, like, the trainees we talked to were very much like, I don't need to choose to be interested in this. This is just part of my work. This is going to be part of my work. I would really say that there's a generational shift from this is a specialty to this is just part of what I need to know. And I think that's, came about because it's more widespread, right? But I think that it's just, it should be integrated from the get-go. And we really did see some, like, from therapists to student doctors saying, I can't opt out of this. So it's just this, I just need to know it. And I think that's a good shift.
And I think that's an indicator maybe the younger generations have less stigma about it.
Absolutely, yeah. So we talked to therapists that said, I used to go to parties and I say I'm an addiction counselor and I would like a conversation stopper. And now people are like, cool, I don't want to do it, but but it doesn't it's not a conversation stopper anymore. I also want to, I think, take the opportunity to put a plug in for peers in ER setting. Right, we know that works pretty well. It doesn't have to be a social worker or it could be a peer. That model works really well. We know it does.
And I assume you will know.
A peer specialist.
And that down on several. Having somebody, whether it's in the doctor's office or the ER office or with the EMTs, there's a place, and to get a peer credential is a lot easier, just easier is not the right word. It takes less time. Cost per hour in the ER room, per day, $20,000, $30,000.
And the Medicaid, so if they're certified by the state, they're Medicaid reimbursable, right? And so I would just say yes, but there's nothing that replaces that one-on-one connection. And some doctors are really great at it, and some of them are not so great at it, right?
Stopping point, we can break for lunch and then continue Q&A, or do you have some other technology?
This is as good a stopping point as any. We can sort of pick up with the tools again when we come back, and then other Q&A.
All right.
Good for everybody? Why don't we come back here in about 20 minutes? Are you going to be here the whole time? I know Gary, I think, might have to leave. I'm going to hit the road, and you're in charge. Yeah, we're going to anoint you. double pay. There you go. Okay, 20 minutes, so about 25 till.
Oh, thank you.
Everybody's still online and we're ready to get started again. If we're ready to get started again, then I will turn the floor over to our presenter to give us some more insight.
We will do our best on that. Thank you. I fired up here so that I could do a couple of things, and here's what I was thinking about, like path forward. If I take a couple of minutes and just walk through these tools, I want to talk about the needs assessment itself and specifically, not talking down to anybody, but someone had to show me the bells and whistles about how to get around this document easily. So I want to share some of those hints with you, and then speak to a couple of other tools, and then I am going to pull up that ArcGIS tool so that I can speak to it in greater detail, and I will just not click on the elements that are contained the IQVIA data.
When you speak to that, we give
Yes.
us a little bit more insight about the process that needs to go through to get approved for all of us to have access for it too. Because I know you mentioned that it's still going through some of the reviews.
Yes, yeah.
What that takes, that would be great.
Okay, that sounds good. Okay, so am I good? Display or connect to wireless display?
You're looking for duplicate. Oh, maybe it's right here. You want to just duplicate it. There we go. Duplicate. And now it should show.
Swell.
And then you'll hit keep changes.
Oh, I got people for that. My son, he's really good at that. Okay, so what we're going to do is we'll start with just some of the tools, just so that you know kind of what's all in the realm here, and then go back to discussing like how do we apply those. And we wanted to go back and close the loop on some of the points that we were ready to make there when we were talking about specific strategy, like what we think would be an example of a smart kind of a strategy. So what you're seeing here, as you probably know, is the front of the document. And a couple of things that were really simple for me. When you go to the left side of your document and you click on that, and if you have a Mac, it looks a little bit different, but you still have this ability to get to these tools, and you're looking for the bookmark, right? And when you click on the bookmark, if you can click on the bookmark, it gives you the whole document. And so you can see from the preface and the contents all the way to the very, very end, you can find what you want. So when I said before, you can go to the bookmarks, you can look for recommendation and priorities. Here we go. That's the recommendation and priorities. And then you can navigate however you want. So we could have the little preface to that. We could go priority by priority. In this case, in the document, there's always way more information than what we're providing to you verbally. But you'll have the priorities, you'll have them listed, et cetera. So if I want to, and let me just speak to how this is intended. There are a lot of people who want to access what's in the report, and that is primo. I mean, you're in a really good position there. And so when we were thinking about this, we're thinking about how do we be able to go to the depths for the people who really are looking at the data and the methodologies and all of that, and how do we also get the points across about what are the key levers that we might want to pull. And so what we did was we dedicated that first 33 pages or so to the executive summary and the overarching recommendations and how that works, and an introduction to the needs assessment and its purpose, and some of the things like we talked about, the vision and the guiding tenets. So here's the vision in its entirety, and you can go and see the visual with regard to the 5 elements and what that looks like. And then we take that down, if I can click on it properly, to this. And in a document, this is a 2-page spread. If you had a broader view, you'd be able to see that as well. But for each of those tenets, then you'll have more detail. So we always start at the highest level and we back it down. So here are the features of that particular tenet, and then here is the relevant findings specific to that, like what are some key things to know that are in the data somewhere in all of those pages. How is this impacting people? We used the quotes to help you to understand this is how people are experiencing that, and then signals of hope. And we chose one from Kansas and one from someplace else in all of those. And so we did all of that, and then we go back here. Have 11 subsections, chapters, if you will, and those go deep on specific topics that either we deemed as being like particularly important to go deep on, or where there is a tremendous amount of interest. And so when you go there, which is like, I'm used to my mouse, sorry. So here we have factors contributing to substance use in Kansas, and we walk through biological and genetic factors. We walk through the normalization of substance use. This is some of what we were talking about just before lunch. What are the social determinants of health? You hear about that. How does that relate? How about addressing those factors when it pertains to overdoses? How about the drivers that are suspected overdoses? And it goes through lots of detail. I'm just going to the main header pages here. Here's the clusters of vulnerability to risk. This is the introduction to that tool that we were talking about before, and some of that. And at the end of each of these chapters is what we call way forward. And way forward is, okay, specific to this, here Zilka talked about the Kentucky Second Chance Employment Initiative. She talked about Rhode Island's recovery-friendly workplace initiatives. This is where they would be. Now, you can kind of root around that way, or you can just go here. I'm going to get away from there. And I'm going to click on my little magnifying glass, and I'm going to be able to go and find what I want. So if I want to find the Kentucky, I'm going to search for the keyword Kentucky. It's on 6 pages. So I knew this was an example from Kentucky, and it will take you through to the references to Kentucky. And there it is, our way forward, signals of hope, and you can find it. So you can search by keywords by clicking on that magnifying glass, okay? And if you're going through here and you notice something and it's on page 15 or here, but I know there's something else that I wanted to see on page 220. You don't have to scroll at all. You can just go up here. I will tell you that these numbers, these page numbers where we're looking, they correlate to the PDF document, which means it's not going to be the same as page 15 at the bottom, which is the hard copy. It's going to be 4 off because we have 4 front sections that comes before that. So you're going to get, you're going to search for that. And let's say I want to go to page, 120, I don't know what's on page 120, but we do now. And I can get back to this quote. So if you're taking notes or you're going through and you're saying, okay, I want to get back to this or that, but you want to keep reading or jump around, you can very readily get back to a specific area. Let me think here. Those have been the most helpful tools for me as I navigate and look quickly. People, the staff will say, hey, I'm working on this part of the sections, and I can go very quickly, and you will be able to do that too. I would like to say that the table of contents, that's what I was doing. You can also click from the table of contents so that you can see the whole thing and just go from there. Okay. So there's lots of shortcuts if you know where to look for them, and I wanted you to have those. There is a PowerPoint. I'm going to close out of that a minute. There is a PowerPoint that contains 49 slides. Those are slides that you've seen before, slides that we've used to both describe the process as well as to convey specific information. And so they are good. You can use those for your presentation, if you wanted to share it with whoever. It can be used in their entirety. Of course, it's provided to you both in PowerPoint and in a PDF version, and so you can take a section and mix and match and do what you want with those. So those are also available for your use. I will mention these. They're not as fully vetted, I think, as I would like, but we generated through data and through field experience over 300 potential strategies. What were people doing? What could happen? In the appendix, there are selected about 200 of those. You see others that are already attached to the priorities that we collectively thought were merited there. And there was we modeled a rating system. Is this scalable? Is this, all of the sustainable, the things that we talked about earlier this morning. And so there's nothing in there not worth seeing. It's not empirically recommended necessarily, but it is great for generating conversation in meetings, community meetings, et cetera, for just kind of getting out of the box, like, that might be another way for this or that. But so you should know that there are some tactical options. I would also say that, and you may not want this right away, but the public communications on this is really important. So for example, one of the tools that we used to gather people for this process was webinars. And we did 5 or 6 of those over a lunch hour, and we had different engagement. And when Pat was mentioning earlier, like maybe we would get, a specific group of people and have them come here and talk with them. Yes, people are craving that. And they like to share it, and they want the information that's coming back. I think there were 2 that really stuck out in my head. One was where we had the kids come and tell us what this means to them and the kinds of things that they are doing in their schools and in their communities. There was connection between the various schools. The schools are very hungry for support and for help and for what can we do with the limited resources and time that we have. And so there was some of that that occurred after that particular webinar. Another one was where we had 3 people who had done startups. They just saw a need in their community and they went for it. And this was a sheriff in Franklin County? Valley Falls, okay. The sheriff from Valley Falls and what all she had, the people she had collected, and she will be prime for all of what you all are thinking about doing. We had another family in the Wichita area, and then Seth, who came and spoke to the startup of the network. And they talked about, this is hard work, and these are the practical barriers that I ran across, and this is, what really helped us to take off. This is what has sustained us. What do you do when it's bigger now than just you can manage, the startup person, and how do you make that shift? And they left that asking for more. And so I think when I talk about the communications tools, using things like that, convening kind of mechanisms is really important. And then keeping a visual, on the website, kind of a things change periodically opportunity for people will really go a long way to helping to improve this problem of fragmentation and move us towards more collective work. So we've talked about the county profiles. This, speaking to Mr. Hess's question with regard to what is required, all of these, like the county profiles, are developed off of a wide variety of data sources. And so there are data agreements that we have to be able to use that data. In this case, the individual group is called IQVIA. IQVIA accumulates pharmacy data and billing data, claims data, that sort of thing. And they do most of their business with Fortune 500 companies and the federal government. But they have been wonderful partners for this project, and they have a clause in their contract and in our data agreement with them that says that if we are going to go public, which all of your meetings are, with anything, then it requires their approval process. So the vetting process of that was to meet with a couple of people. Zilka and I did that Tuesday of last week. They said, and it was encouraging to us, they were supportive of being public with this information, and they did not see anything but gave us the process. Do this, screenshot that, screenshot this, say that, send it in, and they have a whole committee, I guess, that does that. So that's what we were waiting on, and that's why I've been reluctant about that. Okay, so here we are, and this is that main sheet. I'm on overview of substance use here and the health regions. So we've got the 6 health regions and the critical access hospitals, and it's just a static piece, but we thought important information to have somewhere. Then I'm going to go to overdose, as I said. And the elements that we captured for overdose was suspected overdose calls to EMS, drug or alcohol-induced death rates, drug-induced death rates, alcohol-induced death rates, and drug or alcohol-induced death rates growth, right? So then I can go, and if I want to just know about what's the trend here, that's not a good one, but I'll look at this. So here it is. I want to know how come so much of that map is white, and it probably has to do with the fact that there wasn't a baseline data point, so there was no way to determine the growth. But where we had it, we used it, and you can see then if I go to Marion County, the answers for Marion County to all of these overdose factors that we've looked at, and I can scroll down, and if I'm interested in just the growth rate, then I see that that's at 2%. And so it's a good tool from the perspective of being able to really drill down. EMS response. EMS response is all about estimated minutes to the patient. This is data coming from them. Percent receiving naloxone by EMS, and the percent who were transported to a facility. So again, you can find yourself, find a friend, find who's ever submitting for money, and see what their situation is. And there we go. So you can walk through under this overview for substance, health regions, overdose, EMS response, and then that student substance use piece that we had. We studied here alcohol use, vaping, cigarette use, marijuana use, and then student prescription drug misuse. And I think, if I'm not mistaken, all of those factors are here. Whoops. And that's a static piece. So you can see everything at a glance for a county, or you can bob around if you like. Another main category is the vulnerability to risk. And these are things that you'll recognize because we've just been talking about some of them, but it also has other elements also included. So here's the food environment score, the violent crime rates, homelessness, et cetera. These are things that are under a heading of economy and instability. If I move to resource access, here's where we find what vulnerability cluster people are in, counties are in. Here's our nurse practitioners and where they are operating, licensed behavioral health professionals. Two other factors here in terms of resource access, student to teacher ratio. There's a statistical correlation there in terms of how the relationships behave. And then households without internet is an access issue as well. You can go to health behaviors and perceptions. And, unless you're looking for something specific, once you get the hang of how to navigate this thing, it's all pretty self-explanatory, and it's only interesting if you're looking for something and wanting information. But I want you to just be aware of the range of information here and how that works. Health behaviors and then health outcomes. So health outcomes are things like life expectancy, percent of premature births, infant mortality rate, HIV prevalence, sexually transmitted diseases. The treatment and services is where I need to be careful. The patients, we're looking for the median age of insured patients, the proportion of patients receiving services out of state. That's an interesting thing. You can see the darker the county, the higher the number, and it's really heavy in rural. There are a couple of hospitals in those areas that have contractual relationships with a Colorado Springs treatment facility. And so that when somebody presents to those ERs and may need it, that would be the referral. So that there is some of that going on, and there is some of people just going out of state because they want to. There's something here on payers, and that shows you who's covered by what block grant, commercial, Medicaid, and Medicare. And there's by substance. So these are coming right out of claims data. The opioid, the alcohol, the marijuana, and the amphetamines related. Methamphetamine is still a #1 issue, particularly in our rural counties. I'm not going to go to providers, except to show you that, so here we go. My service types, there we go. We tracked crisis services, detox, inpatient or residential, intensive outpatient, partial hospitalization, MOUD, and SBIRT. Number one, this is not a directory. this is following the claims data, right? And we also found in our process that sometimes people fudged on what they do and don't do. And we used a secondary kind of a column up and really talked to the admissions people, kind of a piece on that. And we see that this is, you've got claims, or we see that this is on your website, or the variety of ways that we identified people. And do you still do, for example, detox services? And they say, well, we would like to, but, and this is important too, the variability of workforce is really, we lost that doctor, or we lost the people who need to do that, and so we're in between and we can't do that right now, but we would really like to do that, and we know it's on our website, but we don't want to take it down because we're intending to do this. And so there's, it makes it really hard. Remember, you probably don't, I remember this map like vividly, that we showed at one meeting that is just like lines everywhere, and this is what people have to navigate to do that. Well, that in large part, I shouldn't say it that way, but availability of the correct staffing really impacts that, how people navigate. So that's another thing to be keeping in mind. But if I were to, this is scary to do live. I'm not going to do it live. If I were to push providers and who does detox, in an instance where that person, it's an individual office or an individual person that we have not found anyplace else except in the IQVIA data, there will be a little note that says, for data purposes, this, we can't identify the specific name of this provider, but yes, in fact, they are a provider of detox services in this region. And so there are a few of those that are there, and that is because some of their information comes from the AMA, and that is a part of their contract with the AMA. So these contracts like follow us big time. So this last main header is workforce. And so this is finding where are the people. Licensed behavioral health providers, this went really straight by people's licenses, per 100 people in need. SUD treatment professionals, licensed clinical mental health professionals, social work professionals, and licensed therapy, family therapy folks are who would come up on this particular map. So this is a,
Can I ask you a question?
yes,
Is that based on where they work or where they live?
it's based on where they work. Except on this map, it's based on where they work. On that first map, in terms of resources, it's also based on where they work. Thank you.
It would be interesting to compare those two.
Well,
There's a lot that,
there's a huge difference, right?
there's a lot that live in Sedgwick County or the county just below us that work in Oklahoma,
Right,
because they get paid a lot more.
that's right. Which would be on the licensing, like BSRB
Exactly.
list or Board of Healing Arts list, or, yeah.
So how do I get out now? Oh, okay, then I'll just unplug. Okay. So this tool is something that we can go into in much more detail, or in whatever level of detail that you want. It has a lot of depth, it has a lot of breadth. And as we're talking about strategies, kind of keep that in mind. It helps to have seen it, to know, okay, yeah, we could probably figure that out using part of this tool. You look like you're about to ask a question, yes or no? Okay.
I don't know what my question is. I've got a question.
Okay, we'll perk on it a little bit there. Oh, no. Okay. So I think I would like first to go back to, get rid of this distraction, like first to go back to anything that we talked about, or, that you've been thinking about here over lunch. Any questions that are perking on that? Continue and finish those conversations. first.
I had just a quick question on the mapping tool, the provider mapping tool. Is that more inclusive of providers than, say, findtreatment.gov? I think we've asked that before, but I didn't remember the response.
Yes, because it's all based on billing data, right? So if you're not on findtreatment.gov, it doesn't matter. I mean, if you showed up in billing data, you're there. There's some limitations to that, right? But it's still very good. So it's about 93% of all claims and prescriptions are captured, which is really as good as it gets when it comes to data like this, but yeah.
Do you happen to know offhand, and no worries if not, how much findtreatment.gov captures for Kansas?
No.
Okay.
So my question, I think, really is, this tool, we'll have access to it at some point?
Yes.
Yes.
That's the time frame. Do we have access to it now?
We have access to it now, so you have.
I know
access
that.
to it now. I mean, because we are happy to share. They generally don't take very long. Like, I'm kind of surprised that we don't have it today.
Yeah.
So I think that
That's
in
the
the
part
next
that we're
week,
waiting
I mean, I'm not talking months, we're talking about days.
Yeah, no,
Okay.
they're very easy to work with. They just have to sign off on it.
Give the group an idea about when
Somebody's on
things might be available
vacation,
for them to
is
go
what
in.
Yeah,
I'm
yeah,
guessing.
I would anticipate, I would be very surprised if you
Great.
don't have it by next week.
Yeah, because it looks fascinating, and I'd like to go in and just do some.
And, you know,
looking
and
at
I just want to reiterate, this is not a directory, right? This
Right.
is a data visualization tool. So if you like, but I know somebody who does MUD in this county, they might not be on there because maybe they didn't bill through the regular channels, or maybe they're in the 7% of earned, right? This is not about every single piece of information being there. It's supposed to give you a sense of the patterns, right? I just want to reiterate that because there might very well be a food pantry or this and that you know of that are not on there. But it's about knowing, in general, what does it look like across the state?
Okay. So when you're looking at, I have so much paper here, on your, I know how to fix it. Oh, yeah. On page 5 is where we were starting, right? So with that, what's sustainable over time and what will save lives in the short run, and what will provide that base foundation for us then to continue to build from, because that's the real key. Where do we get started? Actually, the real key is just get started. Sometimes it's easy to get paralyzed by, is this the exact right thing, or, try it. And as long as it is grounded in some of what we've been talking about here, the specific strategies can vary. And there is remarkable variation between communities. And so they are going to be really good partners for you to talk about those community level priorities. So the first thing, if I were you, would be, okay, now we want to take a really good look at those priorities. And we want to say, is that worded the way that we would word it? Do we think this? Do we want a different one? This is how we prioritize things based on the data and our analysis and experience. But you may have different perspectives, and that is A-okay, which is no sweat. So you'd want to validate your priorities. And then start looking for the strategies. With the priorities where they are, this beginning with MOUD and co-responder model for community level kinds of input, et cetera, is statistically reliable, will help save lives, and will help you to build your network. So we're breaking down silos when we're asking people to work together, right? We are investing in things that will also contribute to our key long-range goals. We want to help to organize and decrease the fragmentation of this particular condition, right? We want to reduce the stigma related to this condition. We want to reset on that. Whatever those are, use the strategies that give you multiple bang for your buck. And so that's why we picked those two. Would you?
Yeah, I would agree with that. I think whatever your priority is, I think one of the things you want to look for, can it affect different parts of the system through one strategy? And I also would encourage you, like, start with your big strategies and kind of big goals. You can then burrow down a rabbit hole and do the details, and it's easy to get lost for us, which is lots of different taxes, lots of different options, right? You can't do it all, but it's then you can see what the options are, and you can give options in your RFPs and say, be creative. Here's a laundry list of things you could do. Pick what works for your community, but then it has to go back to the overall strategy. Is it serving the overall strategy, right? So I encourage you not to, I know this is a big document, there's lots of information there. You know, if it feels like this is too overwhelming, and pull out, okay, what is the big thing we're trying to achieve? And then go back and pull out what you need to make the decisions you need to make.
The other thing about that MOUD that's a good example is in order to, you don't just flip a switch and begin to start to do that, right? There are things that have to be done to prime the pump to be able to do that. So the linking to the pharmacist is smart. There's 103, in 103 of our counties, out of 105, there is pharmacy access. They are a ready and available resource. So who do we need to partner with to turn the money on for them? Or do we show how much it helps with the money that you have? We're going to pick a pilot area and we're going to try this. The pharmacists are begging, the association and many of their members are driving that. We talked here about hospitals and primary care and the nurse practitioners. That's going to take some time to call them together to say, this is our idea, this is how we want to do that. I don't recommend doing that. Like we're talking about this MOUD and co-responders as community level kinds of initiatives, because it would be best to get a couple, 2, 3 communities on board with that, and then learn what that means here in our state. What do we run into? And what have we then, hopefully something that's scalable and replicable from some of that work, and then we can continue to advance it. Yes.
Back on the pharmacist,
Yeah.
does that require, for the pharmacists to do what they've done in other states, does it require legislative or licensing changes in Kansas?
No.
So the legislative change has already happened. That happened in 2003. Right now what's happening is that it was brought to Medicaid for them to approve, and they haven't approved it yet. But the legislative changes happen now. There are some, it's complicated, some restrictions depending on if they're a community pharmacy versus an embedded in pharmacy. You definitely would have to dig into, but there's definitely some. And not all pharmacies want to do it, right? I would then meet with the Pharmacy Association and talk through who would be a good starting point, what needs to be in place to be able to do it. But the legislative change has already changed, so.
Really best practice is MOUD in combination with integrated care. So that's like a behavioral health provider. And then the supportive services to navigate, we were talking about this, the housing, the transportation, those are serious issues. So is there a community, bonus points to the community who wants to take on simultaneously, how do we engage our physicians and our MOUD prescribers and integrated care simultaneously? And, you know, so there's a lot of legs behind that, but it's not just a switch to flip. It's like, okay, it's in the data. We can help you find that. You will find that. You know some of this from your own experience. don't be afraid of multi-layered, multi-year kinds of initiatives, because it can be done.
Yeah. Yeah, and I think another example would be for the co-responder model, there's some things that are happening in Kansas that we should address to make that more possible. One of them is that first responders have different levels of Narcan administration. And so we've talked to police officers that also moonlight as firefighters, and they get to a call and they're like, okay, which uniform am I wearing? How much am I allowed to? Or that is unnecessary, right? So like on policy level, there's some things we could fix relatively easily. For each of these recommendations, there's always a suite of things that need to happen. And I think part of your RFP and one of your strategizing would be you have to ask people, what barriers do you anticipate? What do you have to get in place, right? What are the action steps to be actually be able to implement something as complex as MOUD? What does have to be in place? I call it the Jackson Pollock approach to public health. It's not do this, do this, do this, do this. It's like, what are the set of things that have to be in place to be able to do this right?
And that goes back, I guess, for people who may be online still, to what Silke said earlier, which is, now I can't remember. I should have eaten that cookie instead of just put it in my bag. The point is this. The point is that some communities can move faster than others, but you control the strategy. So that's the point, right? The strategy is we're working towards more MOUD. So when we go out there, work with the willing, right? Send your RFP out there, have the parameters the way it is, see what you get, and how far along you'll be able, through the data that you have access to say, okay, this might be a better shot. They've got more infrastructure, or these people are really organized and there's no infrastructure, but man, are they the willing? And, so it gives you some more information also for when you're making selections of grantees. And then you really can control, I guess, if anybody can control anything, those systemic components. The systemic components, broad, specific campaigns that help us to reduce stigma, or that reinforces the community action that's occurring in those communities. That's important. The multi-year kinds of strategies in your grant making, the purposeful collaborative skill building, like how do we want to do that? You will know what your strategy is there, and you have the mechanisms to be able to guide people towards those strategies. So it's not helter-skelter.
Any questions or comments from the group? Any others? Online? Do we have anybody online? Okay.
Thank you, Sarah.
Anybody still here?
Yeah. So I guess we would just close by saying thank you for the opportunity to do this remarkable work. It has been not just a labor of love. It's been a lot of work, and it's been very fulfilling work, and we thank you for that opportunity. And we look forward, as we're able to support you, to answer questions or do what might be helpful as you go forward.
Well, thank you for being able to have this discussion with us today. It was nice to be able to ask questions and hear your answers and your methodology and those kinds of things. You don't always get that as specifically from just a presentation, so it was nice to be able to have you guys to answer that stuff for us. Yeah.
This was a way better format than just taking us through the report, because we've got the report. We've looked at it. We can read it. This was very helpful.
I think that's it. All right. We're scheduled to reconvene on the 8th. Is that what I saw on the thing? So our next meeting is August 8th. Any additional business that we need to go through before we call this meeting a done, adjourned deal?
Well, before you do that,
Oh, should always know.
so Krista and others, here's what I think about. We have some very specific kind of priority strategies from our partners here. I'm just curious about what we do next and how we do that. I could envision us coming to the next meeting and kind of rehashing some of this stuff and trying to figure out priorities, but I wonder, Krista, if you all have thought about what is our homework taking away from this conversation to help us be efficient in our time to move forward?
Thank you, Sandra. I think one thing that Krista and I have talked previously, I will admit we did not recently talk about this, but I think a frame of reference in terms of how the board is considering the longevity of the dollars would be a really great starting point. I think one thing that we have been discussing when we do talk about the dollars as staff is, they are going to come over this time period. If you were to divide that evenly, this is what this looks like. And we're using that really as an example for people to understand what those dollars really look like annually instead of kind of like a giant big number. So I guess from my perspective, it would be helpful for the board members to kind of think through, is the longevity part of a goal? What overall long-term are board members interested in? Because I think that in the end will really help define what type of framework we do and what type of opportunities we're able to bring to you. I think that would just be a really helpful point.
So maybe then if you all, this is just an idea, you all could send us in the next couple of weeks, here are the specific things we want you to think about. Because here's the decision we're going to try to get to in next meeting or the meeting after. That way, our time here is really taking all that information and moving it forward versus having a random conversation. Doesn't sound right, but you know what I mean.
Yeah, we can definitely do that 100%. And so we'll work with Krista on that.
I have a question about when this is going to be available for organizations outside of our board.
Yeah, I think there was previously interest in the board formally adopting the report. So I think maybe at the next meeting, that might be a board business component if you guys are interested in doing that. So then that would then be posted on the website and whatnot at that point. The county profiles will likely be up before that. Our communications person is on vacation currently, but he's going to put those up before since they're not technically part of the report itself. Just with those data components like you saw today. And another piece of information that actually Shanna reminded me, something that we've talked about as staff too, and based on the conversation you all have probably in August, is thinking about developing some kind of white papers based on these recommendations and what the board might be interested in, and kind of what would that look like moving towards something like that of frameworks for funding is one of our goals. I know most people hate doing strategic planning. Behind the scenes, Alyssa and I are probably going to be writing a strategic plan for our own brains. But those white papers might be a good way of not putting you all through a strategic planning process, but getting to something like that as a goal.
Well, I think that's important because otherwise we're going to go down multiple rabbit holes over the next year about, oh, this looks cool, let's do this. So I really hate strategic planning. However, I do think it's important that we agree to whatever that is and stick with that. And maybe a little pot on the side to say, oh, that's cool.
Anything else?
No, this is Sarah, and I couldn't agree more with what Sandra is saying and really Krista is saying, I don't mind strategic planning. And I think it would benefit us to know that we have some really set goals, and we know, because we can't achieve goals that we don't set. So, and we're just going to be throwing darts. So I think it would be important for us to set some goals and to set some, just to give us a roadmap on where we're going to go.
Okay. Thank you for that. And with that, we will adjourn this meeting and we will see you all